Hello, my name is Kathleen Varices. I'm a staff hepatologist at Brigham and Women's Hospital, and today I'll be speaking to you about portal hypertension, varices, and other vascular disorders of the liver. I have no industrial relationships with biomedical, pharmaceutical, or medical device companies, and I receive no sponsorship or any form of financial support from such companies. The objectives of the talk are to review the pathogenesis, manifestations, and treatment of portal hypertension, review the management of varices in the setting of portal hypertension and cirrhosis, review the other vascular disorders of the liver and their diagnosis, presentation, and management. Here is an outline for the talk that I will present today. Portal hypertension will be discussed, specifically the definition, pathophysiology, and clinical manifestations. I will discuss varices and their classification, treatment, and management. Budd-Chiari and portal vein thrombosis will also be reviewed, as will hereditary hemorrhagic telangiectasia and pileosis hepatis. To begin, portal hypertension, in a global sense, just reflects high pressure within the portal system. You can see from this drawing that there are many vessels in the splanchnic vasculature to consider. Specifically, the superior mesenteric vein, the splenic vein, and inferior mesenteric vein are the three vessels that comprise the portal vein, which we will discuss in detail during the rest of this talk. Measurement of hepatic vein pressure gradient is a way to assess for portal hypertension. In the procedure, the balloon is inflated to obtain a wedge hepatic venous pressure and then deflated to obtain a free hepatic venous pressure. The measured wedged pressure reflects the splanchnic vessels, since there are no valves in the portal venous system or within the liver itself. So to summarize, the hepatic venous pressure gradient equals the wedged pressure minus the free. And portal hypertension itself is estimated by the hepatic venous pressure gradient. Normal pressure within the portal system is about 5 millimeters of mercury. Any portal pressures up to 10 millimeters of mercury are considered portal hypertension, but not clinically significant. Once the pressure is equal to or greater than 10 millimeters of mercury, you begin to see the complications of portal hypertension, and it is also referred to as clinically significant portal hypertension. Cirrhosis itself is influenced by the presence or absence of portal hypertension in regards to prognosis. When thinking about cirrhosis, you should think about it as compensated or decompensated. In compensated cirrhosis, there's a median survival of greater than 12 years for our patients. In decompensated cirrhosis, which is manifested with ascites, variceal hemorrhage, and hepatic encephalopathy, the median survival is 1.8 years. Decompensated cirrhosis is the manifestation of complications from portal hypertension. There are two components of portal hypertension in order to consider and think about: an increase in portal flow to the liver, as well as an increase in resistance to flow. The increase in flow is influenced by splanchnic vasodilation, hypervolemia, increased cardiac index, secondary to decreased vascular resistance. Splanchnic vasodilation itself is found in all forms of portal hypertension, and it is not solely a result of a cirrhotic fibrotic liver. It's an independent process which contributes to the forward flow theory, and it's mediated primarily by increases in nitric oxide in the circulation. Hypervolemia is vasodilation of the systemic circulation and leads to arterial underfilling. Neurohumeral vasoconstrictor release of norepinephrine, angiotensin II, and leukotrienes in the liver and systemically contribute to increases in sodium and water retention from the kidneys, as well as increases in antidiuretic hormone secretion. In 1953, Kowalski and Abelman described, quote, warm extremities, cutaneous vascular spiders, wide pulse pressure, and capillary pulsations in the nail beds in cirrhotic patients. These changes are initially compensated by increases in the cardiac output to greater than 4 liters per minute per meter squared. However, ultimately, there is failure to maintain an arterial pressure despite increases in plasma volume. The second component of portal hypertension is an increase in resistance, which is divided into fixed or mechanical and dynamic or functional. In a normal liver, there's no resistance to flow. The sinusoids are open and allow for passage of blood easily into the hepatic vein, as seen in this diagram below. Here is a histologic representation of a normal liver, and again, you can see there's no resistance for the blood cells to flow within the sinusoids. However, with injury, fibrosis occurs, and there is, quote, capillarization of the space of Dease and narrowing of this space due to stellate cells which lay down fibrous matrix. These cells narrow the sinusoids to narrow the passage of blood and therefore increase resistance of blood flow. As you can see in this histologic representation of acute alcoholic liver disease, there's resistance to blood through the sinusoids due to the absence of clear sinusoidal passage. Resistance can be dynamic, and that's demonstrated as vascular smooth muscle contraction can be influenced in the portal venules by rat models which showed intrahepatic vascular resistance can be decreased with vasodilators. There's also hepatocyte swelling, which improves in the setting of resolution of acute alcoholic hepatitis, and statins can show improvement in endothelial dysfunction and fibrosis. This slide is a comprehensive review of what we will talk about and what we have discussed. We've discussed the two components that contribute to portal hypertension, specifically increased resistance and increased flow, and the contributors to that. We will next move on to the manifestations of portal hypertension, specifically varices, and then lastly, the various treatments, including medications, tips, as well as endoscopic therapy. The location of the resistance of flow is important and identified by the prehepatic or pre-sinusoidal, intrahepatic or pre- and sinusoidal resistance, as well as post-hepatic or post-sinusoidal. And the location of the resistance determines the primary clinical manifestation, so it's very important to think about. Back to this illustration of the portal system, a reminder is that the flow of blood through the portal system is in this direction. Prehepatic portal hypertension will involve diseases that occur injuring the portal vein. Pre-sinusoidal may be within the portal vein or portal triads themselves, but pre-sinusoidal, not yet at the level of the sinusoids. Sinusoidal involves the sinusoids themselves and inflammation and scarring within the liver. Post-sinusoidal usually is relating to the hepatic vein, and post-hepatic is usually outside of the liver. In this chart, hepatic vein pressure measurements as well as the different types of portal hypertension are illustrated. To the left, we have the types of portal hypertension that I reviewed on the previous slide, and then to the right, we have the venous pressure measurements that correlate with various causes of portal hypertension. An example would be sinusoidal portal hypertension from NASH or alcohol, where the wedged pressure would be elevated due to sinusoidal pressure leading to resistance in the portal vein. The free pressure would be normal as the balloon's deflated, reflecting normal right-sided heart pressure, and therefore the gradient is elevated, indicating that this is perhaps a sinusoidal cause of portal hypertension. And the various measurements and scenarios are outlined well in this chart. The clinical stages of cirrhosis are seen below. Compensated cirrhosis then moves towards decompensated cirrhosis, and then late or further decompensation, which then ultimately progresses to death. In compensated cirrhosis, there can be mild portal hypertension ranging from 5 to 10 millimeters of mercury. And again, if greater than 10 millimeters of mercury, this is considered clinically significant portal hypertension and may present with or without the presence of varices. In decompensated cirrhosis, variceal hemorrhage can occur, as well as ascites or hepatic encephalopathy. And in further decompensation, the patient can manifest with recurrent variceal hemorrhage, refractory ascites, hyponatremia, hepatorenal syndrome, recurrent hepatic encephalopathy, as well as jaundice. It's important to note that if hepatic venous pressure is reduced to less than 12 millimeters of mercury, there can be protection from a variceal hemorrhage occurring. However, if the venous pressure is greater than 16 millimeters of mercury, there's a higher risk of death. And if the hepatic venous pressure gradient is greater than 20 millimeters of mercury during an acute variceal hemorrhage, this predicts the failure to control bleeding, early rebleeding, as well as death. There are a few ways to assess for the presence of varices. One that we are very familiar with is invasive and involves performing an endoscopic evaluation with EGD. The other is a non-invasive measure using platelet counts greater than 150 and a liver stiffness measurement with less than 20 kilopascals as a value. In these patients, non-invasively, the probability of varices being present is about less than 5%. Therefore, recommendations are that these patients may not need an EGD for the initial assessment of varices. When do we repeat EGDs and when do we check? In patients with compensated cirrhosis without varices, a repeat EGD is performed every 2 to 3 years. In compensated cirrhosis with small varices, a repeat EGD is performed every 1 to 2 years. And it's important to remember that a repeat EGD should be done at the time of any decompensating event in any patient. To the right, this would be an example of no varices, and this would be an example of small varices which flatten with insufflation. To prevent a first bleed in a patient with medium to large varices, medications such as non-selective beta blockers like propranolol or nadolol can be used, carvedilol, or endoscopic variceal ligation can be performed. It's important to remember that no further EGD is needed for monitoring if patients are started on a non-selective beta blocker or carvedilol. It's also important to remember that dual therapy is not offered to patients. For example, the use of non-selective beta blockers or carvedilol, and on top of that, doing endoscopic variceal ligation. It's also important to remember that we do not perform TIPS to prevent a first bleed in medium to large varices, and these are outlined above with the large varices being displayed in the top figure and a varix that has been banded in the bottom figure. The therapy for medium to large varices that have not bled was reviewed in the previous slide, and again, we have propranolol, nadolol, carvedilol, and endoscopic variceal ligation. The recommended starting dose, therapy goals, and maintenance follow-up are outlined above. For propranolol, the dose is 20 to 40 milligrams orally twice a day, and the dose is adjusted 2 to 3 days with a maximum dose of 320 milligrams per day if the patient has no ascites and 160 milligrams per day with ascites. Therapy goals are a heart rate no higher than 60 and a blood pressure no lower than 90, as well as monitoring in subsequent visits for the target heart rate to be met, and reminder that, again, there is no need for EGD. With nadolol, the dose is the same, 20 to 40 milligrams. However, it is once a day dose. And the dose is adjusted every 2 to 3 days with a max dose of 160 milligrams per day if no ascites and 80 milligrams per day with ascites. Again, the therapy goals are unchanged with a heart rate no higher than 60 and a systolic blood pressure no lower than 90. And monitoring for target heart rate at future visits is important, as well as the reminder that no repeat EGD is needed. For carvedilol, the dose is 6.25 milligrams PO once a day, and then after 3 days, it can be increased to twice a day, which is the max dose. There's no heart rate goal, and the blood pressure over 90 is the only target. And this should be continued indefinitely with, again, no follow-up EGD needed. And lastly, varices that are banded should be re-examined every 2 to 8 weeks until there is eradication of the varices, and then the first EGD repeated 3 to 6 months after that, then 6 to 12 months thereafter. For acute variceal bleeding, the management is inpatient with a hemoglobin goal of 7 to 9, with transfusions being conservative. IV ceftriaxone, 1 gram IV daily, is given for a maximum of 7 days, and octreotide is also given for 2 to 5 days to help with splanchnic vasoconstriction. EGD is performed within 12 hours. If there is bleeding present, then endoscopic variceal ligation is performed, and here is an example of actively bleeding varix, as well as variceal ligation on that bleeding varix. TIPS can be considered quote-unquote early within the first 72 hours in select patients if the hepatic venous pressure gradient is greater than 20 millimeters of mercury, the patient is child score C with a score of 10 to 13, or child score B with active bleeding. TIPS can also be considered if bleeding recurs despite endoscopic variceal ligation and the use of vasoactive drugs. The classification of gastric varices is outlined on the left, with GOV 1 and 2, isolated gastric varices 1 and 2. GOV 1 is the more common presentation of gastric varices, and it's esophageal varices that extend into the lesser curve. GOV 2 extends into the fundus. Isolated gastric varices 1 is located solely in the fundus, and isolated gastric varices 2 is somewhere else in the stomach. The risk of bleeding is highest in isolated gastric varices 1, followed by GOV 2, followed by GOV 1. Large size and red spots on these varices are also a risk of bleeding, as well as severity of liver dysfunction. When gastric varices are discovered on screening endoscopy, primary prevention for bleeding is similar to the patients with esophageal varices with medications such as non-selective beta blockers or carvedilol. There is no preemptive TIPS performed for patients with gastric varices. However, in the setting of active bleeding, you can perform a TIPS or use cyanoacrylate glue. Moving on to Budd-Chiari syndrome, which is also known as hepatic venous outflow obstruction. There is secondary Budd-Chiari syndrome, which can occur from tumors such as HCC, as well as external compression from strictures or scarring, and primary Budd-Chiari syndrome, which can be caused by thrombosis within the hepatic vein itself. The presentation is abdominal pain, ascites, and liver enlargement, and is considered to be a multifactorial disease. There are several prothrombotic disorders that can be present in a patient with Budd-Chiari, and you must seek out all the potential risk factors, even if the patient has one obvious risk factor. For example, if they're on OCPs, you still must do the workup to rule out underlying cause of thrombosis. This next slide goes into detail about the various tests that should be done in patients presenting with Budd-Chiari syndrome or portal vein thrombosis. On the left, we have the prothrombotic condition that could be considered and should be worked up in the presence of a clot within the hepatic vein. For example, a myeloproliferative disease, PNH, Behçet's, antiphospholipid syndrome, factor V Leiden, factor II gene mutation, inherited antithrombin deficiency, protein C and S deficiency, hyperhomocystinemia, oral contraceptives, and pregnancy. To the right, we have the diagnostic features and testing that should be done in patients with Budd-Chiari or portal vein thrombosis. And these are various tests or procedures, for example, the JAK mutation in myeloproliferative disease, as well as a bone marrow biopsy to look for dystrophic megakaryocytes. And in factor V Leiden, for example, you would want to check for increased protein C resistance and then test for R605Q factor V mutation. So this chart delineates the various tests that should be done as part of the workup in any patient. And again, if they are on oral contraceptives, cessation of those medications is important. However, you should also look for other causes of underlying thrombosis risk. The diagnosis and treatment of Budd-Chiari, again, applies to patients presenting with symptoms that are classic, such as elevated liver enzymes, pain, ascites, and hepatomegaly. A Doppler ultrasound is performed, and focus should be on the hepatic vein, the inferior vena cava, and portal system. If the ultrasound is negative or indeterminate, the patient should undergo angio-CT or angio-MRI. And there should be an evaluation for venous obstruction, then secondarily looking for a rule out of tumor encasement or other structural lesions. Blood tests, as mentioned, should be done to look for procoagulant disorders, myeloproliferative neoplasm, PNH, etc. And the treatment is correcting the underlying risk factor when possible, for example, cessation of OCPs if present. However, it's also important that anticoagulation is indefinite unless there's a complication from anticoagulation that occurs. There can also be percutaneous angioplasty offered when it is possible to be done. Portal vein thrombosis can be acute or chronic, and it's really the successive stage of the same process with slightly different management. Again, there's a combination of inherited risk factors as well as local factors present when a portal vein thrombosis is discovered. Some of the local risk factors are cancer of any cause in any area, focal inflammatory lesions, injury to the portal venous system, as well as the underlying presence of cirrhosis. In acute portal vein thrombosis, there is sudden formation of a thrombus within the portal vein. The presentation is abdominal pain that may be progressive over a few days, fever and ileus, infarction if the extension of the thrombus goes into the mesenteric veins, and even blood cultures that can become positive with Bacteroides species being commonly identified. The diagnosis of acute portal vein thrombosis is made with CT, and that should be done with and without contrast to confirm the presence of a thrombus. And if that is not successful or available, a Doppler ultrasound can be performed. The management of acute portal vein thrombosis is to quickly involve surgery if there's signs of sepsis or multi-organ failure in order to explore the vessels. The patient should have anticoagulation for at least 3 months. Low molecular weight heparin should be used, and then oral medication. And again, indefinite therapy if there's a permanent thrombotic risk factor identified. For chronic portal vein thrombosis, or portal cavernoma, the portal vein is obstructed and replaced by a network of hepatopedal collateral veins, and this is easily diagnosed on imaging. Because of this network of smaller veins replacing the larger portal vein, portal hypertension occurs, and sometimes patients present with bleeding varices. However, this is better tolerated than bleeding varices from patients with portal hypertension from liver disease, because oftentimes the liver is normal in these patients. There can be hypersplenism as a result of the portal hypertension, and these veins can compress the larger bile ducts and lead to portal cholangiopathy. In treatment of chronic portal vein thrombosis, the aims are to prevent and treat variceal bleeding, prevent and treat thrombosis, and to treat cholangiopathy when it's indicated. In order to prevent variceal bleeding, we use primary prevention tools such as non-selective beta blockers, as we would in other causes of portal hypertension. However, TIPS is not feasible in most patients due to the abnormal anatomy of the portal vein in these patients. We want to prevent and treat thrombosis and consider long-term anticoagulation if there is no cirrhosis present, or again, if permanent risk factors for thrombosis exist. And lastly, the cholangiopathy that can occur with obstruction of the bile ducts can lead to stones formation and possible even cholangitis, so stent placement may also be used. Portal vein thrombosis and cirrhosis is a special category, and the prevalence increases with the severity of cirrhosis. It is less than 1% in compensated cirrhosis versus 8 to 25% in transplant candidates. And here on the right, you see an example of a cirrhotic patient due to the small shrunken liver, the presence of ascites surrounding the liver and throughout the abdomen, and this yellow arrow pointing to a thrombus within the portal vein. It's important to rule out thrombus related to HCC in all patients who might have cirrhosis. And the patient should be evaluated also for factor V Leiden mutation, MTHFR, prothrombin gene mutations as well. Anticoagulation in patients with cirrhosis is done on a case-by-case basis, and if extension occurs into the SMV, they're at risk for bowel infarction, and that risk is quite high. Hereditary hemorrhagic telangiectasia, or HHT, is a rare autosomal dominant disorder presenting with widespread AVMs found in the lung, brain, and liver. In HHT families, there are mutations discovered in one of two genes, endoglin or activin receptor-like kinase type 1. And these genes encode for transmembrane proteins that are involved in TGF-beta signaling and the pathways that are expressed in vascular endothelium. And this is illustrated on the drawing on the right. The diagnosis and management of HHT is reviewed. Again, in the symptomatic patient presenting with classic symptoms of HHT, such as epistaxis, telangiectasias, or if they have a family history of HHT, or a family history of a stroke. In these patients, the liver can appear nodular due to nodular regenerative hyperplasia. And focal nodular hyperplasia, or FNH, is a benign focal lesion that can mimic HCC in the setting of NRH. A liver biopsy is not needed for diagnosis, and what you can see here on the right is the vessels that are present throughout the liver and the AVMs denoted with these red triangles, and also the presence of cardiac enlargement due oftentimes to increased cardiac output. The treatment of HHT is dependent on the presentation. So in patients with heart failure or portal hypertension, we do the standard of care management. Bevacizumab, which is an antibody to vascular endothelial growth factor, can also be used. And in patients with biliary disease from ischemia to the bile ducts, ursodiol can be helpful to improve liver enzymes, and if cholangitis is present, management as is standard of care. In some rare patients, acute biliary necrosis syndrome can occur, and in those patients, they can progress to worsening liver failure, and thus a transplant evaluation is indicated. Pileosis hepatis are blood-filled cysts within the liver, and the pathogenesis of this disease is uncertain. It's possible that it's related to damage of the sinusoids from altered blood flow, which then lead to dilated central veins, or perhaps necrosis of hepatocytes, which then lead to blood-filled cavities within the liver. In 20 to 50%, there's no known trigger. However, it's common to associate certain drugs with pileosis, such as steroids, OCPs, azathioprine, and methotrexate, which are common drugs used in our patient populations. MRI is a gold standard test in looking at the radiologic diagnosis, and it's important to note that regression of this disorder can occur if medication use is a cause and therefore stopped. Bleeding lesions can be treated with either hepatectomy or IR. In summary, portal hypertension has severe implications in cirrhosis. The goal in portal hypertension treatment is to prevent clinical decompensation. In Budd-Chiari syndrome or portal vein thrombosis, a workup should be done for thrombotic risk factors, and anticoagulation is the main treatment in Budd-Chiari syndrome. HHT and pileosis require no treatment unless the patients have symptoms. Question number 1. As part of the workup for new onset ascites, a woman has a measurement of portal pressures. The following pressures are obtained: wedged hepatic venous pressure, 20 millimeters of mercury, free hepatic venous pressure, 6 millimeters of mercury. The most likely cause of her ascites is A, right heart failure, B, prehepatic portal vein thrombosis, C, alcoholic cirrhosis, D, Budd-Chiari syndrome. The answer is C, alcoholic cirrhosis. The patient has portal hypertension given the hepatic venous pressure gradient of 14 millimeters of mercury. The normal free hepatic venous pressure makes A incorrect. The elevated wedged hepatic vein pressure makes B incorrect. The ability to perform a measurement of hepatic vein pressure and the normal pressure within the hepatic vein makes D incorrect. Question number 2. A man with no routine health care presents with acute variceal hemorrhage. It is discovered that he has chronic hepatitis B. The bleeding episode has been treated successfully with esophageal band ligation, and he is hemodynamically stable. What should be done prior to his discharge on hospital day 5? A, tips before discharge to prevent future bleeding. B, ultrasound to evaluate for HCC. C, start ciprofloxacin daily for prevention of spontaneous bacterial peritonitis. D, repeat EGD before discharge for further banding. The answer is B, ultrasound to evaluate for HCC. Performing an ultrasound in this patient with chronic hepatitis B is the correct answer. He has not had routine care. Since it is unknown if the patient has HCC, an ultrasound should be performed. HCC can be a cause of portal vein thrombosis, which could precipitate variceal bleeding. Answer A is not correct because TIPS is indicated only in rescue situations where there is recurrent bleeding despite endoscopic variceal ligation and non-selective beta blockers. Answer C refers to treatment of SBP, not esophageal variceal bleeding. Answer D is not correct because repeat EGD for endoscopic variceal ligation should occur in 2 to 8 weeks after the initial banding.